I'm being blinded by the light, so I assume that means we're ready to start. I'm not sure how many people were able to dial into the talk I gave during the virtual component of the conference, but at that point I talked about an earlier effort to provide some guidance around use of therapeutic cannabis for chronic pain. We have updated that, so I'm going to be talking about that for this lecture. My disclosures, nothing particularly ominous, no for-profit relationships to declare, some grants from CHR and Health Canada. So this is the guideline that we put out in 2021. We did what's called a British Medical Journal rapid recommendation. It was very focused. We simply wanted to understand, did the existing evidence and what we understood about patients' values and preferences suggest whether or not it was reasonable to offer a trial of cannabis for chronic pain. And we found the evidence suggested that amongst patients that had not found sufficient relief with other forms of available care, it was not unreasonable to offer a trial of non-inhaled cannabis. And it was a conditional recommendation, so it means the final decision would depend on that patient's values and preferences. Now, there was a lot of limitations with this particular piece of guidance. One, it focused on non-inhaled forms of cannabis because that's the evidence that we found. But when we know at data from the Canadian context, yes, it is true that chronic pain is a major indication for people using cannabis therapeutically. But when you look at how they're using it, this green bar is people that are using for inhaled purposes, as you might expect. Non-medical is very, very dominant. The dual user is very dominant. But even amongst medical users, it's 38% are choosing to use inhaled forms of cannabis. So for us to produce guidance that doesn't deal with inhaled forms of cannabis is a major limitation. So we said, all right, we have to do something more. So we started off by forming a large panel, and the panel included 6 patient partners. These are all individuals that lived with chronic pain. Some of them were currently using cannabis therapeutically. Some had used it in the past. Some had not. So we wanted a diversity of experiences. We had a couple of methodologists. We had a large number of clinical experts, some you will recognize. But they represented a number of different areas, from primary care to psychology to addiction to pain specialists. We had rheumatologists on board there. So again, the key criteria for being able to participate in a panel member is you could not have any financial or intellectual conflict of interest, right? So intellectual means you've been publishing a lot of papers saying you either know that it works or you know that it doesn't work, and we felt that would preclude you from being able to look at the evidence in an objective fashion and simply make the recommendations on that basis. What perspective did we take? Well, we took a patient-centered perspective. So we did not take it from the perspective of society or from the payer. We considered this from the individual that would be living with chronic pain. And when we met with our various stakeholders, and we met with people from patient organizations, from Veterans Affairs Canada, from different clinical groups, from regulators, they told us 7 areas that they wanted us to try to provide guidance. And so we undertook to complete a systematic review of the evidence to inform each of these 7 areas. Now, we use something called the GRADE approach in order to make our clinical practice recommendations. Using the GRADE approach, you can either make a strong recommendation, and it could be in favor or it could be against, or you can make a conditional recommendation. So what allows us to make a strong recommendation? Well, we have to see evidence that either the benefits greatly exceeds the harms or the harms greatly exceed the benefits, right? If it strongly shows benefit but not much harm, we can make a strong recommendation in favor. If the harms greatly exceed the benefits, we make a strong recommendation against. We have to believe the evidence. So we have to have at least moderate or high certainty evidence so that we're confident that the effect we're seeing on benefits and harms is likely the true effect on benefits and harms. And we have to have evidence that if patients were to see this evidence on benefits and harms, that essentially all of them would make the same decision, right? If we have these things, we can make a strong recommendation. What if we don't have these things? Well, we make conditional recommendations when there's a close balance between benefits and harms. You know, they're fairly aligned. There's not an obvious winner between the two. We make it when we have lower certainty in the evidence. We're not sure if we can believe it. And if we perceive that if patients were to see this information on benefits and harms, there would be a lot of variability in what they decide. Some patients would be interested in trying something, others would not. So again, if we have any of these conditions, we have to make a conditional recommendation. Now, when you make clinical decisions, evidence alone is not enough. We have to understand patient values and preferences. So we began the process by doing a systematic review of patient values and preferences. Now, we had done one for our rapid recommendation and published it. We updated it. We found a lot more studies. I was surprised how active publishing in this area has been. But we actually found 35 eligible publications. They all included adults living with chronic pain, either due to cancer or non-cancer causes, asking them about their perceptions around use of therapeutic cannabis. So what did we learn? Well, we found moderate to high certainty evidence that many who were using therapeutic cannabis valued the benefits that they received, and which is why they continued to do so. And this was even in the face of sometimes experiencing adverse events, which people indicated in some of these studies that they did. We found that patients with chronic pain, including those with substance use histories, preferred cannabis over prescription opioids and other prescription medications, sometimes out of the perception that it was natural, but sometimes because they perceived it was less harmful in particular than opioids. We found that younger age and a history of cannabis use were associated with a higher likelihood of substituting cannabis for prescription medications. And most patients, again, these are patients using cannabis therapeutically, preferred formulations either with high CBD or balanced ratios of CBD to THC versus recreational users, which had a greater preference for the high THC products. And again, females, novice users, patients with certain types of disorders, those who endorsed use of cannabis for medical purposes only, were particularly inclined to choose products with low THC. Males, experienced users, patients who used cannabis both recreationally and medically and used higher THC products, preferred smoking or vaporizing versus other modes of administration. So the kind of background or history that people brought into this indicated where they would lean in terms of how they would administer cannabis therapeutically. Most patients obtained their cannabis from legal sources. However, the majority actually wanted to receive a prescription from a physician. They would like to have that type of involvement, not always easy to get. And the decision whether or not to use cannabis therapeutically was influenced by both the perception of positive and negative social consequences. So again, if they were getting criticism from family and friends, less likely to be interested. If they felt that there was support from a healthcare provider or other connections in their social network, they were inclined to think about it. Cost and accessibility influence patients' decisions to use medical cannabis. Cost was the most common barrier for different forms of administration. So some forms of administration were cheaper than others, and that drove the decision to use them. Healthcare providers who were uninformed or unwilling to discuss therapeutic cannabis were identified as a barrier to use. And although adverse events were frequently reported, many patients felt they were not severe enough for them to discontinue use. So they were placing a slightly higher value on the benefits they perceived they were achieving versus some of the harms they also acknowledged. And concerns about medical cannabis included addiction, tolerance, losing control, acting strangely, and patients with greater concerns about these that placed greater value on these concerns were much less likely to endorse interest in using cannabis therapeutically. So again, makes sense. We found low certainty evidence that patients had a very mixed level of comfort around the use of therapeutic cannabis. Some studies found that there was very different proportions that might be interested in looking at this therapy. Patients report variation in the effectiveness of managing chronic pain depending on the product that they use. They also felt overwhelmed by the choices available and noted that finding the right strain or product required a great deal of personal experimentation. Many patients expected at least 25% pain relief in order to justify using therapeutic cannabis, but for that they were willing to spend up to $100 per month. And patients selected dispensaries based on online reviews, discussion with friends and acquaintances, again highlighting that there was not a lot of information being found through sort of traditional routes in healthcare providers. Now we said, that's great, we've learned quite a bit from these 35 studies, but it's not enough, we want to learn more. So we conducted our own qualitative study. We interviewed 52 participants living with chronic pain. Half female, half were greater than 55 years of age. Most identified as white or European, but we did have a little bit of representation from other ethnic groups. And you see we tried to get some distribution across Canada. And most had lived with chronic pain for more than 10 years, and almost all of them experienced pain on a daily basis. 77% were currently using cannabis therapeutically, 19 had in the past, 4% had never tried. So again, some variability in terms of representation, experiences. And about half also use cannabis for other conditions than chronic pain and for recreational purposes. So we had a mixture of medical only and also what we've been calling this conference the dual users. So what did we learn? Well, first, we got the findings that we learned from our systematic review were reinforced. So everything that we had learned in that review, these 55 individuals also ended up telling us, but they told us some other thing as well. They said there was variability around reasons that they chose to use medical cannabis if they had, but these included ineffective pain management from what they were trying before, or the perception as cannabis as being a safer option. Reasons for not trying cannabis included not enough information, pain already managed appropriately, concerns about negative side effects, and cost. There was variability in preferred product types and methods. So people that were using inhaled forms sometimes highlighted the more rapid onset. They say, I feel the effects of this within minutes, as opposed to oral forms, which could take an hour or longer. But at the same time, participants told us they perceived that oral routes were probably safer, less harmful, fewer side effects such as coughing, burning in the throat, harms to the lung. They were also seen as convenient, discreet, and more socially acceptable. So again, this idea about the stigma came up quite often, and the idea that, smoking or inhaling your treatment had a very different social optic than taking a couple of drops of an oil or a capsule. Some noted that oral methods had less effect than inhaled, or that they disliked the taste. Inhaled forms of cannabis were considered cheaper and more readily available. Now we did ask people, we said amongst those that were inhaling cannabis for therapeutic purposes, would you be willing to switch to an oral formulation? And quite a few said they would if it was more affordable or if it provided similar effects. Now, when we asked people that were using oral formulations, would you be willing to switch to inhaled, they pretty well universally said no. So we kind of learned that, if you're using oral, you're not really willing to switch to inhaled. If you're using inhaled, you do have some interest or flexibility. You can deal with the cost and in some cases, some of the experiences and rapidity of effect. So that's what we learned about patient values and preference, and here was our first clinical practice recommendation. And it was this: should we offer a trial of cannabis for medical purposes compared to care without cannabis in people living with chronic or non-cancer pain? And again, we could make a strong recommendation against, conditional in favor, or strong in favor. And any conditional recommendation is a candidate for shared decision-making because it's conditional on patient values and preferences. We don't know patients' values and preferences until we talk to them. So we started off with a systematic review of randomized controlled trials. We had done one earlier, we updated it, we found a few more trials, 34 randomized controlled trials, mainly on chronic non-cancer pain, but a handful on cancer. Length of follow-up was not particularly impressive. Placebo was the most common control. They predominantly looked at plant-derived cannabinoids or synthetics, small handful of endocannabinoids. And again, as we found with the original review, we had a lot of oral and sprays, a little bit of other methods, but no inhaled. Don't worry, we looked for inhaled another way. So what did we find? This is a busy table. You only have to focus on the red here, though. So what we found is, if you look at pain as one of the outcomes, we had 28 trials, just short of 4,000 patients. And when you look at the proportion of patients that achieve the minimally important difference in pain relief, which we defined as 1.5 centimeters on a 10 centimeter scale, in the cannabis arm, it was 53%, which is pretty impressive. But in the placebo arm, it was 42%. So we see a large non-specific effect. The risk difference is 11%. So what that means is you have to treat around 9 patients or so versus placebo to get one that will report an important reduction in their pain. So it's not a large effect, but it means for that one person in 9, there's some benefit. We had moderate certainty evidence for that. When we looked at physical functioning, also a statistically significant benefit, but a risk difference of 4% means you have to treat 25 patients with cannabis versus placebo to get one that will report an important improvement in their functioning. Sleep quality, the effect was a little bit bigger than that, risk difference of 7%. That means you have to treat 17 patients for one to report an important improvement in their sleep quality. So we're seeing a picture emerge of some modest benefits, won't work for most, appears to work for a minority in terms of pain, sleep quality next, and then for a smaller number, physical functioning. We had high certainty evidence that there was no benefit versus placebo on emotional functioning, role functioning, or social functioning. So it didn't do much for any of those 3 outcomes. Now that's benefits. What about harms? Well, there was an increase in things such as vomiting and drowsiness, but the risk difference tended to be, again, pretty modest. 3% risk difference, 4% risk difference. Where it came a little bit higher was dizziness, and we found a subgroup effect here. So for patients that are treated for less than 3 months, the risk difference was about 8% more versus placebo would report at least an episode of dizziness. But once you got to the longer follow-up trials, more than 3 months, that risk difference moved up to 33%. So the dizziness, at least having an episode, started to increase with longer periods of treatment. And again, there were other outcomes they looked at in terms of harms, impaired attention, diarrhea, nausea, memory. Yes, there was a significant increase versus placebo, but again, the risk differences are pretty modest, between sort of 2.5% and 5%. So again, looking at something like a risk difference of 4%, got to treat 25 patients versus placebo to get one more that will experience an episode of diarrhea. So statistically significant, but fairly modest additional risk. What about the more serious harms that aren't reported in randomized trials? Things like psychiatric disorder, suicide, suicidal thoughts, mania, hallucinations, delusions. We had very little evidence to inform these. You'll see all of this came from a single study of 430 patients. And really, we had sort of either very low, which means we have no confidence, or low certainty. But where we had the low certainty, and low is not great, we didn't see any evidence for an increased signal. So none of these were significant for suicide or suicidal attempts or these other outcomes here. Now we've got a lot of evidence for increased risk of these harms with recreational use of cannabis. But we only looked at pure therapeutic administration, And for those studies, of which there are very, very few and we need more, we did not see compelling evidence for these harms. With the caveat, this is low certainty evidence coming from a single observational study of 431 patients. Other ones, sort of same thing here, disturbance in attention, falls, motor vehicle accidents. Again, you're going to see that these are all from the same study. Withdrawal symptoms and dependence, we have a few more studies to call upon, but we're really looking at low or very low certainty. Where we do have low, there doesn't appear to be a significant increase in risk in these, but it's low certainty. So new evidence is quite likely to change our estimates. So, what have we learned about this? Well, what we learned is there is the possibility of modest improvement in pain, physical function, and sleep quality, not in emotional functioning, role functioning, or social functioning. There is the possibility of an increase in a number of adverse events, but they typically tend to be mild, and the increase in risk tends to be fairly modest. So are we in a situation where the benefits clearly exceed the harms? I would say no. Are we in a situation where the harms clearly exceed the benefits? Probably not again. They're pretty closely aligned. And so we're in the position where we either have to make a conditional recommendation in favor if we perceive that the majority of patients might be interested, or a conditional recommendation against if we perceive the majority of patients would be disinclined. In any case, it's a situation for shared decision-making. And so this is what we decided, reflecting upon the values and preferences information. So again, if standard care is not sufficient, because this is what we learned from values and preferences, right? The patients told us, I became somewhat interested if things hadn't worked that are typically available. So we said, if standard care is not sufficient, we suggest, and that's because it's conditional, a trial of cannabis for medical purposes compared to continued care without cannabis in people living with chronic or non-cancer pain. And again, it's a conditional recommendation. And it's conditional because the benefits and harms are closely aligned, and we think that individual patients are going to make different decisions based on that evidence, and we don't know what they're going to decide until we talk to them. Second question, right? Because now you're going to say, but what about inhaled or non-inhaled? This is what you missed out on the first guideline. So, second question, if the decision has been made to offer a trial of medical cannabis, should you offer non-inhaled or inhaled forms? So, this is a summary of what we derive from the values and preferences information that would be relevant to this question. What we perceive from looking at the evidence from the studies we looked at, plus our focus group evaluation that we did, is that patients living with chronic pain typically, not always, but typically place higher value on the possibility of increased pulmonary harms with inhaled versus non-inhaled, and a lower value on the possibility of improved pain relief with inhaled versus non-inhaled. We said typically because it's not universal, but when we looked at the information and the feedback, that seemed to be the sort of majority opinion amongst the patients we talked to. So when we look at evidence from RCTs, and what we did to find the evidence on inhaled forms of cannabis is we relaxed one of our eligibility criteria. In the systematic review I showed you before, we wanted studies to have a minimum of 1 month follow-up. Why? Because this is chronic pain. It doesn't get better in a month, right? You're on a treatment often for years. So we wanted trials to look at least 1 month of follow-up. But we said we've got to pull in whatever evidence we can from inhaled. We're going to relax that, and we'll take trials with shorter follow-up. And so these did have shorter follow-up, sometimes only 8 hours after administration of a product, sometimes a bit longer. And what we found is the possibility that inhaled might be more effective than the non-inhaled, but you know, it's imprecise, it overlaps with the confidence interval for this, so we're not sure. We sort of saw a similar type of benefit on pain, the possibility that it could be more effective, but the follow-up is much shorter, and there was no head-to-head comparison of inhaled and non-inhaled formats. So we're looking at non-inhaled versus placebo and inhaled versus placebo. When we looked at other outcomes, such as physical functioning and sleep quality, they basically showed the exact same effect. So whether it's inhaled or non-inhaled, you had a small but statistically significant benefit in terms of improved physical function and improved sleep quality. And neither of them showed any compelling benefits on social functioning, emotional functioning, or role functioning. So, what about harms? Well, the inhaled showed the same sort of harms as the non-inhaled. In addition, they suggested the possibility of an increased risk, although modest, in asthma, chronic wheeze, phlegm, shortness of breath. No significant difference in lung cancer. But again, all of this is very low certainty, meaning we have very low confidence. The signal is going in the direction that we expect, but we really can't say with any degree of certainty. So, what's our recommendation? They appear to be similarly effective for the most part, which is not a huge effect, but on pain, sleep, and physical functioning, there appears to be some benefit for minority. They appear to have a similar harm profile, possibility of some additional pulmonary harms with the inhaled form, but the evidence is sort of very sparse at this time. So we rely on our values and preference statement, where the patients in general told us they placed a bit of a higher value on the possibility of avoiding pulmonary harms than they did on the possibility of potentially more effective pain relief through inhalation. And because of that, we made a conditional recommendation, if you're going to offer a trial of therapeutic cannabis, to start with a non-inhaled form. Now, we did have a remark with this. And we said, because every patient's not going to make the same decision, patients who do not achieve sufficient pain relief with non-inhaled forms of cannabis may wish to then trial an inhaled cannabis product. If they do, they should probably consider use of a vaporizer versus smoking because of the desire that we've seen to avoid pulmonary harms. So again, it depends. It depends on the patient in front of you. It depends on their values and preferences. But we think that the evidence that we have supports offering this as a first option. Now, what about people that are living with chronic pain, they're using prescription opioids, and they're interested in reducing their dose of opioids? We heard this both from our systematic review of values and preferences and our focus groups. Should these people be offered therapeutic cannabis as a strategy to help them? Well, we found 6 observational studies that looked at opioid consumption amongst people living with chronic pain. And it appears when they gain access to therapeutic cannabis, their average morphine consumption goes down appreciably by about 41 milligrams morphine equivalent per day. But the evidence is very low. Observational data, plagued by confounding, no strong control group. So looks very promising, but our confidence in that effect is quite limited at this point in time. What about, does adding on cannabis do anything additional to help with their pain or their function or their sleep? Do you have an additive effect? Does it augment benefits? We didn't see evidence of that. We had moderate certainty that it does not provide additional improvement on pain or sleep. So these are randomized trials where patients were all taking opioids and half the group got access to cannabis, half got placebo. We did not see an additive effect. So by adding cannabis onto opioids, you're probably not going to get a bump in either of these. We only had very low certainty evidence for these other outcomes, but again, it didn't look as if it was doing much. And again, we really didn't know if it's doing a lot, at least in these trials, in terms of a few of the other beneficial outcomes or in these 3 adverse events. But what do we know in general about the harms associated with taking opioids or the harms associated with use of cannabis? Oh, sorry, I should also state, after we did our systematic review, but just before we met with the panel to make the recommendation, this study came out in JAMA Network Open, and it actually was the largest observational study that we'd seen. So we decided that we would show this to the panel in addition to the systematic review. And this study was quite interesting. They looked at over 4,000 patients that were exposed to cannabis, 2,300 that were not, but they had this control phase where these were the patients before they were offered therapeutic cannabis. Well, again, this is observational, so some of these patients were simply given access and some weren't. But you can see that their sort of morphine equivalent dose was quite stable before the intervention period, or the pre-intervention period. Here's where, part of those patients were given access to therapeutic cannabis. And again, if they weren't, they pretty well stayed the same. If they were provided with cannabis, their use of opioids went down. And it went down whether they were prescribed low doses of opioids at baseline, moderate doses, or very high doses. The pattern was quite compelling and consistent. About a 50% reduction in the use of opioids in those patients that were given access to therapeutic cannabis. Again, observational data. Looks impressive, looks consistent, biggest study that we're aware of to date, but we can't call this strong evidence. This is sort of low certainty, but promising. So again, we're in this situation where we have sort of low certainty to very low certainty that it could help patients reduce their use of opioids, possibly quite a substantial degree. All the observational studies are showing this sort of very large signal. It does not look as if it's going to augment benefits on any other outcome, but we do know that patients are interested in trying to reduce their use of opioids. We don't see evidence for an increased risk of harm in adding cannabis onto opioids, so we ended up making a conditional recommendation once again. What does a conditional recommendation mean? It means for the patient that's interested, you say, here's the best information we can give you on the possibility of benefit. We have low certainty that you could reduce your opioids substantially. Doesn't look as if it's going to provide additional benefits in any other area. We don't think it's going to augment your harms. If that's enough for you to try it, that's reasonable. If you are not convinced by this evidence, it's perfectly fine for you not to try adding on therapeutic cannabis. So again, conditional recommendation in favor of offering a trial. Seeing a lot of conditional recommendations, so this is a gray area. What about this other issue where you have an individual that's living with chronic pain and they're not achieving sufficient relief with standard care, and they are now coming to you and they're saying, should I consider opioids? Should I consider cannabis? Time's up. I better hurry. Thank you. All right. So for this, we did what's called a network meta-analysis. There's only been one trial that's ever directly compared cannabis and opioids in a head-to-head study. But we took every study of opioids versus placebo and every study of cannabis versus placebo, and because of the common comparator, we modeled what the effectiveness would be of each of them. So this study will come out shortly. But to be very, very quick about it, we found no compelling evidence that when you compare opioids to cannabis, that there is any difference in pain relief, physical functioning, or other outcomes. They both have these sort of small effects for a minority of individuals, and one does not appear to be any better than the other. Now, the only place where it differed is when we looked at discontinuation due to adverse events. And individuals that were receiving cannabis versus opioids were much less likely to discontinue the trial due to adverse events. They both have adverse events, but the ones associated with opioids were more likely to result in discontinuation. And of course, we know, and I put in green the ones supported by high certainty, you can potentially fatally overdose on opioids. That is a possibility. So, based on this information about the effectiveness appears to be similar, but higher risk of discontinuation due to adverse events and the possibility of rare but catastrophic harms with opioids, we once again have made a conditional recommendation in favor of offering a trial of therapeutic cannabis before offering a trial of opioids. It's simply because of the difference in the safety profile, and what we learned from values and preferences that patients are a little bit more likely to consider cannabis in many cases versus an opioid. These were the 3 remaining PICOs that our stakeholders wanted us to answer. We did systematic reviews. We found no evidence to make a recommendation. We will be making some clinical statements about this to provide general advice from experts in the area, but we don't have enough to make a recommendation. And that's it. Thank you very much for your attention. I'm not sure if I have time for a question.
I think we have time for one question.
One question.
Thanks for the great presentation. I actually have one question about the patient and the preference and value part. So you conducted a survey. So my question is, did you include a part of patient with cancer? Did you observe any difference of like using cannabis between the cancer patient and the non-cancer patient?
So for our qualitative study, we did one-on-one interviews with each individual. The interviews took on average about an hour, but some a little bit less, some a little bit longer. Our eligibility criteria was chronic pain due to cancer or non-cancer causes, but we did not include anybody involved in palliative care. We did not see, so again, we're looking, if someone had chronic cancer pain and was involved in palliative care, I would imagine their values and preferences would be quite different. They are not going to have much concern at all about addiction or long-term harms. They are thinking very much in a short term. But because we didn't involve those patients, we didn't see any great difference between the kinds of concerns and values and preferences that they raised. So again, we felt it was reasonable to include cancer and non-cancer pain as long as it was chronic and not palliative, and we didn't see any signals suggesting there was important differences when we, only took people in non-palliative care.
Thank you.
Thank you.